Ladies and gentlemen, the Carnegie Foundation for Cancer Research is absolutely delighted to welcome you to the 9th edition of the Carnegie Lectures. My name is Beverly Henry, one of the directors. The other two directors who are here present with us today are Carleen Carnegie and Dr. Cliff Riley, who you will hear from a little later. At the heart of our mission is a commitment to providing the public with vital information on cancer, its causes, treatments, and the cutting-edge medical and technological advances that could lead to a cure. Today, we seek to achieve both of our core objectives: to educate and raise the necessary funds to provide the scientific equipment essential for advancing our research agenda. We encourage you to visit our information table throughout the event to learn more about ongoing efforts and how you can contribute to this important cause. Together, we can make a difference in the fight against cancer. I want to extend a warm welcome to President Lincoln Edwards of Northern Caribbean University, alumni and friends, as they celebrate the 100th anniversary of Alumni Homecoming. A special thank you to Mr. Danita Murray, Alumni Director, and Mr. Harold Clayton, Federation President, for their leadership and support. Many of our alumni have traveled from abroad to be with us today, and we appreciate their presence in this momentous occasion. It's a pleasure to acknowledge members of the nursing, pharmaceutical, and medical professions, many of whom have registered for continuing education credits, and we're also joined by exhibitors, presenters, and representatives from both government agencies and the private sector, all of whom play a vital role in the ongoing work to combat cancer. We are grateful to all our partners who have helped make today's program possible, including Riza Art at rizaart.com, Humming.media, Island Gully Falls, OMG, Optimal Computer Systems, Tropics View Hotel, Villa Pharmacy, Consolidated Health Services, and Janssen's Pharmaceuticals, who's represented today by Mr. Desmond Rowe, who is here to gather important insights for future initiatives. And of course, we are honored to welcome our eminent panel of experts in the fields of cancer diagnosis, research, and treatment. They will soon be introduced to you, and we look forward to their insights on the timely and crucial topic of emerging technologies in cancer diagnosis and treatment. Before we begin the presentations, I invite you to join me in a moment of reverence as Dr. Paul Giles leads us in an opening prayer. Kindly stand.
Hello, everybody. Those on the periphery, I'm asking everyone to be quiet at this time because it's the beginning of the cancer lecture series. We'll be focusing on cancer, so we need the attention of everyone at this time. It's time for prayer. Those on the periphery, those who are speaking, I'm asking everyone to be quiet at this time as we seek the Lord in prayer. Holy Father who art in heaven, we're just thankful to Thee for bringing us together at this particular forum. We're thankful for the distinguished presenters that we have here to share information on this dreaded disease, cancer. We're just thankful for the Carnegie Foundation and the collaboration with Northern Caribbean University over the years. As we listen to the various presentations, may the presentations be stimulating and enlightening so that we can be better informed as to how to deal with this dreaded disease, cancer. May the Lord continue to bless and keep us and be with the proceedings and help that all may go well, and we all will be edified as we listen to this cancer research series. May God bless you all.
Thank you so very much, Dr. Giles. I'd like to present, ladies and gentlemen, our first presenter, who is Dr. Morton A.C. Frankson, President of the Bioethics Society of the English-Speaking Caribbean. Dr. Frankson is a UE-trained public health physician who pursued further studies at the Loma Linda University in Loma Linda, California, USA. He was a lecturer with the UE Faculty of Medical Sciences at Mona, Jamaica, and Nassau, Bahamas, and has served with the Jamaican Ministry of Health. He was Chief Medical Officer of the Turks and Caicos Islands and at the Jamaica Union of Seventh-day Adventist Disaster Relief Agency, ADRA. He is currently the President of the Bioethics Society of the English-Speaking Caribbean, BSEC, and has been a member of the Medical Association of Jamaica since 1977. He is chairman of the National Mirror Committee of the Bureau of Standards in Jamaica and founding member of the equivalent mirror committees in the Bahamas, and a recent first vice president of the Jamaica Statistical Society. Dr. Frankson serves as physician at the Northern Caribbean University Mandeville campus and is the director of research and statistics. Join me, ladies and gentlemen, in welcoming Dr. Frankson to present on the topic, Ethical Considerations in Terminal Illnesses. Dr. Frankson. Now, ladies and gentlemen, I know you can do better than that. My friend Louise Bennett would say, what sort of fenke clapping that you're going on with? So please, let us really welcome him. Great. Thank you very much, ladies and gentlemen.
I think it was a topic why they didn't clap. Yeah. Can we have this on the screen, please? Good day, everyone. Not hearing me at all, eh? I'm hearing me, though. Good day, everyone. Thank you so much for the opportunity to speak to you today. It is a pleasure and a high responsibility. You heard my topic, ethical considerations in terminal illnesses. Next slide, please. I have no disclosures. I guess I'm the one who is to do that, yeah. You can put it up back again, please. Okay, great. Wonderful, wonderful. No disclosures. And let's get right into some definitions this morning. The World Health Organization has defined terminal or life-threatening illnesses as a condition that is incurable and will likely result in death. And usually by that they mean within a few days, a few weeks, a few months. Otherwise, everybody would have been on a terminal condition because we all will die at some point, hopefully after a very good and productive long life. And the reason that this is classified as terminal illness is because the condition is seriously advanced, and they have sought the best that medical care can offer us for whether it is a cardiovascular disease. It's shocking to know that 17.9 million people die from that every year, or whether it's cancer, 9.3 million people die from that every year, or any of those other listed things there, respiratory, diabetes, and other problems that relate to some of the miscreants that sometimes we allow in our lifestyle. Is this better? Is this better, everybody? Wonderful. Okay. This is to be distinguished from chronic illnesses or non-communicable diseases, many of which can, if not managed properly, lead to terminal illnesses. The duration is different. The chronic diseases are long-lasting, and you don't necessarily have to die from them. And in fact, there is good technology now that is allowing us to reverse some of them. I think that's just wonderful news. And the thing about these conditions is that they're conditions that the body doesn't have a way to resolve them quickly, so they progress. And even that is preventable. They are not usually contagious, and although HIV/AIDS wants to classify itself as a chronic non-communicable disease, as a chronic contagious disease, and communicable definitely. So that would also make it a long-lasting thing because of the success that we have had in treating it. And with good compliance, it's wonderful to see how that can be managed now. The startling thing is that death is around us all the time. Globally, 17 million people die before the age of 70 years old. And it's 74%, 3/4 of all deaths are people who die before the age of 70. And in fact, up until recently, most deaths were in children under the age of 5 years old in countries that actually do not have the resources to do that, middle income and low income countries included. Thank God for work that was done here and elsewhere in the world that has helped, for example, to reverse that with regards to protein energy malnutrition. And the impact of chronic non-communicable diseases is one that leaves a country usually in a beggarly state. Poverty, because it is expensive to treat the chronic non-communicable diseases. And it affects the country, it affects the society, locally and regionally, and it affects the individuals and their families as well. These are some of the things that if we make choices for and are not wise in making the choices, that can lead, and I could show you a lot of other slides, exercise and so forth, but you have seen that talk before. Let's go back to deaths. Deaths in Jamaica is quite something. In 2019, we were looking at 285 deaths per 100,000. It's an adjusted rate, which means it's adjusted for things like your sex and so forth. And so it's an average rate, but it is very close to the reality. And this actually was a decrease from the year 2000. That's encouraging, but we still need more improvements as we are not at the top of the list for preventing untimely deaths in the region, the inter-American region, and definitely in the world. We would love to get there because we are, by nature, world-leading people. And I could give you more facts on that, but I think that you get the point there, that we're having too many deaths in our country. And a lot of these are actually due to terminal illnesses, but it's not usually the typical way of persons dying. Now, cancer. I mentioned that as one of the things that leads to death, unfortunately, at times. The adjusted mortality rate for men per 100,000 for prostate cancer is 53.4, lung cancer 3.9, and colorectal cancer 11.2. For women, it is breast cancer followed by lung cancer, stubborn second place, even across the sexes, and of course colorectal cancer also stubborn across the sexes. And these are figures that the Pan American Health Organization lets us be aware of, and we should pay attention to them. The idea behind relating to people to change their course of life so that they do not die in an untimely way is that you are actually trying to get the best for people. And in medicine, there are commonly noted 4 goals of medicine. One is to relieve symptoms. And may I hasten to add that one of the best ways to relieve a symptom is to not get the symptom in the first place. Prevention is the best way to relieve symptoms. But there are other good ways to relieve it as well in many, many instances, and that just keeps improving as the medical technology improves. Another is to cure where possible, and another is to promote longevity, and the fourth is bettering a person's person-oriented and population quality of life. We're going to talk a little bit in the few minutes that are remaining in my talk on values when it comes to using these 4 goals to drive us as we look at terminal illnesses. Just a little bit of background in a nutshell. There's a field in philosophy that is called values theory. There's metaphysics. There is epistemology, logic, and values theory, among others. And it is where ethics sits. And it is very field specific. It deals with what is right and what is wrong. And when it comes to terminal illnesses, you cannot escape ethics. Healthcare delivery, ethics is involved. And if you're in business, ethics is involved. If you're in politics, ethics is involved. If you're in religion, ethics is involved. We're going to look at a little bit of business, but also the bioethical areas because they're kind of inseparable. And we're going to talk, it's good for me to mention that there are 2 ways that I could go with this. One is a casuistic approach, and the other one is a principles-based approach. And both of these involve sound thinking, whether it is inductive thinking, which is more thinking with probability involved. Is it likely that? Whereas the other is deductive, which is you state certain clear facts and then you make what is the deduction from that. Casuistry, don't try to read this slide, please, unless you want to, is it's really a very flexible way of looking at something from clear-cut cases, paradigms, to real-life cases. You look at something that has happened in the past that was clear-cut, it came to a decision on the matter, and now you have something in front of you that you still haven't figured out what is the most moral way to attack it, and you go back and you look at what you did in the past, and as you did it you use principles from what you did in the past, and then you actually now use those principles and apply them, if possible and if correct, into the present situation. And it's really very, very good in that it is good that if the past things that you look at were on a firm foundation, you can actually, with more confidence, use those as the things that have precedence and use them to inform what you do at the present time. And, you know, we do that when things conflict, when we are uncertain about other things that we're dealing with at the moment, and we use it in a variety of other situations where might not even conflict, but we can't even see clearly where to go because this is such a novel thing for us. You remember the recent pandemic? There were a lot of ethical issues involved in the recent pandemic, and in fact it was called the novel virus, wasn't it? Because there was a lot that was not clear. And indeed, we fumbled our way through that, and here we are today. There is also a little branch from that that is called situationalism or situation ethics, which is something else that I will not get into at this time, but just to mention the name for us. The principle-based approach to ethics talks about respect for autonomy. The right to decide is a right, and it's ethical. It shows that you respect somebody's ability for their brain to be able to make a choice. The fact that I don't have to coerce you to do something is ethical because it respects somebody's autonomy. It means I wasn't trying to run your life for you. You actually made your decision in a voluntary way. And the fact that there is confidentiality and privacy, and if I want to consent to you, it's voluntary and it is informed. That also is me respecting you, whether it is dealing with goods and services or preventative or therapeutic or palliative practices, and sound religious or cultural values. Appreciating those in a person is also showing respect for a person's ability to govern themselves, their autonomy, and of your cultural values and your practices as well, if they are legal, by the way. If they are legal. I just want to say one other thing, though. It's not everything that is legal that is ethical. Some things were ethical and legal at a certain time, and as we progress, things have moved on, we know better. They still remain on the books as a law, but they need to be changed. That also has to be borne in mind. And when we do that, we're not just showing respect for individuals' autonomy, but for a community's autonomy. Beneficence is another one that's doing good. And it could be in transactions that we do, or it could be biopsychosocially, when we look at all that is involved in improving, for example, compliance and adherence to beneficial interventions. And even the Good Samaritan role is also there as something that we should note. Non-maleficence is probably one of the principles that everybody knows, which is first, do no harm. And if you know a little Latin, that sounds like primum non nocere. And it means that really we should minimize the harm as much as possible. It's an idealistic statement to say that we do no harm to anybody. Even handing out a survey to somebody, just asking them to check what is their sex, is today something that could harm them. We have come to some interesting times that we're living in now. But we find the most beneficial way to do it, and the non-maleficence is what we're going for there. And then there is the famous justice, fairness and equality, and timely access to fitting informative care opportunities that include a variety of things that people expect us to have. Whether you're here at the university or if you're running a health service, we expect you to, for example, make sure that you have at hand an ID badge. Because I have a right to know who I'm talking to when that person comes up to talk with me, especially when the place is a place of business. And whether it is in a hospital or at a health service, or if I go to do a home visit, etc. All of those things come into the important business of caring for the terminally ill. And there are a variety of others who would actually come up with more principles than these 4 principles. Business, for example, adds principles like no discrimination as one of the principles. And nursing might add fairness or fidelity, faithfulness, or truth-telling. In medicine, we just put them together and stock them under respect for persons. And education has its own additions that it would do too as well. We have a duty to care for people And we can either use a duty-based approach to caring for the terminally ill, or we could use ends justified the means approach. When you use an approach to caring for the terminally ill, when you use a duty-based approach, we say you're using a deontological approach. From the words deon, which in Greek means duty, and logos, deontological, logos means the word. And science, the word on the topic that we're discussing at the moment, or to know. Now, the thing that makes something deontological or duty-based is that the action that we take is obligatory. It's just right. And we avoid that action if it's just wrong. It's very clear-cut to us. And, we will not do it regardless of the consequences. For example, if somebody tells you when you're dealing with somebody who is dying that you should fleece them out of their money, which, sad to say, is not uncommon. We wish it were never, but it's a particular time when the elderly get picked on. You should just not do it. You should just not fleece people out of their money, even if they are going to leave a lot of money and you have a great idea of what you could do with it. You have a duty just not to do it. Even if next month you can't pay your light bill, you must not steal from the person that you're taking care of. I'm glad I get to mention this point, because too often I see this and it breaks my heart that not just relatives, but sometimes even caregivers find ways to take advantage of the terminally ill and the elderly who are dying in this one. The approach that we have here is a formal approach. It's actually called formalism. And the gentleman who came up with this approach was Immanuel Kant, and time will not permit me to mention all that he has to say there. But he does call it the categorical or unconditional imperative. You just must not compromise. There are certain things. By the way, I need to let you know, these great philosophers, they were solid Christian people. Solid Christian. A strong Catholic man, Immanuel Kant. And a man whose life was dedicated to Christ. And he's coming up with things here that will affect us in how we teach religion, how we do business, etc. And, his idea is how you arrive at what is right is by a group of people coming together and reasoning it out. And when they have decided that this is right, live by that. Sort of like some of our committees that we have. Sir David Ross criticized him in some aspects and of that kind of an approach that a committee, for example, can decide what is right for you. But we do have some of that coming over into how we practice managed care and universal health coverage, etc. Time again will not permit me to get into that. I'm here changing everything on my slides on my computer, and I am not changing it on yours. I do apologize for that. They said men don't know how to multitask, and I just proved it a while ago. So I do apologize for that. However, it did give you a chance to listen to me and not look at the slides. So that's a plus for coming out of it. There are wonderful things about human rights that must be adhered to when you're caring for the terminally ill. And the Kohlberg's theory of moral development, some of you as nurses, etc., know about these particular theories. And the 6 stages, they're there listed on the slide, and I'm sure you can't read them. I apologize for that. And every right of a client or patient entails a duty of the servant or the caregiver. Which brings in the other issue now of standard of care. Standard of care is really something that we have a duty to adhere to. And that is very important at any stage of care, whether you have a terminal illness or whether you have an innocuous illness. You need to know that you are being offered the standard of care for that particular thing, whether it's a little abscess or whether it is cancer. That's the least we can do for humanity. When you see how wonderfully the human body was made by a great God, our duty to God and to the created beings, us, is to offer the best care in the situation. And that's the thing about standard of care. What is standard of care if somebody fell down here in this gymnatorium is not the same as standard of care if you fell down by the orthopedics department at the Mandeville Regional Hospital. Because you do not have some of the fancy technology that they have. But what you must do is do the best that you can do right here in the situation that is there. And what we need to do with that is to make sure that we do as much as possible to, even when somebody is ill, prevent further disability for them. And when we are dealing with the ill, the terminally ill, we're actually signing a contract with them. And self-efficacy is really important in all of that. Now, the other aspect of the philosophical approach, as I mentioned earlier, is the one where we say the ends justifies the means. That has its place too in the caring for the terminally ill, because there are some things that we actually know that we have to keep doing, even though there is not research for it yet. But that is the best thing that looks reasonable to us. And we should always do that in the highest valued manner. When you're taking care of the terminally ill, like any other person, make sure that you also pay attention to wills and the power of attorney. Make sure there's consent for treatment, consent to withdraw from treatment, or and who is going to be the surrogate, and who is going to be the executor when you're doing that. Diagnosing doesn't go away when you are terminally ill. You need to be able to diagnose, firstly, to see that the person really has a terminal illness. And secondly, you have to now, as you are taking care of them, if there are other issues that come up, you have to make sure that these issues are addressed. The person is on a process of dying. The person is on a process of dying a journey. The person is not yet dead. So your job is not to push them into death. My job is not to push them into death. My job is to treat them as ethically and as responsibly as ever. And things like life support and when to stop the ventilator, using narcotic analgesics, etc. And even the issue of your living will also in some countries, including euthanasia, becomes a big issue that I just don't have the time this morning to do for that. But what our job is to support people who are dying. That's our job. Whether it's a ventilator, medication, nutrition, or fluid balance, looking at some unresolved issues and what might be conflicting about them, what might be some confounding events, where there are medical uncertainties, and so on. And these are all things that a court of law would actually bear in mind. There is a lot of technology that is included in a ventilator these days. And the issue of consciousness versus unconsciousness is also a most important issue. I keep talking and not changing the slides, but I'm wrapping up now. These things have ethical implications. These things sometimes may end up in the courts. These things may involve withdrawal of life support. They involve a person claiming that they have a right to die. Why should I suffer anymore with this disease that has gone, this prostate cancer that has infiltrated into my bone marrow and my bones and is paining me and nothing can help it? And then all of those things come in. Medications and food and narcotics, etc., are all important issues. And lastly, we should, if we are so privileged, ask for an ethics committee to look at issues when we are caring for the terminally ill that can guide us, that can protect us, etc. But unfortunately, in our low and middle income countries, we hardly have any ethics committees in our health institutions. So what you have to do in situations like that is form ad hoc ethics committees with whoever is the chief officers of the organization, etc., and keep it as objectively as possible. And in the past, that's how it was. At present, that's how it is in many places. And in the future, in Jamaica, there are others who will be now having ethics committees to actually deal with that. The things about these things are that they reduce conflict and they help us to bring matters in a more prepared way to the court, and it may help us to be dealing with persons in a more professional and caring manner, and it can facilitate decision making, and it can facilitate education that people need to have, that sometimes we who are so close to caring for those persons didn't see that that is added information that the person or the family could have, etc. And it all helps in decision making and in a variety of ways. So, all of this is for patient autonomy, quality of life, less suffering, good health. Even CPR should be applied to the terminally ill if they wish to be given CPR. But if not, you have to honor and respect their wish to do not resuscitate, and so on. And there is faith, hope, and charity. These three. But the greatest of these is charity. I really have to apologize for my mishandling of the clicker, but I'll leave you with this slide as I go. Thank you very much. Need the mic, okay. I'm going to move right into that presentation of mine was just my warm-up for the day. And I hope it gave you some guidance as you go through the other sections. I want to thank Mrs. Henry for introducing me. And it is now my privilege to introduce Dr. Cliff Riley, the Director General of the Hazardous Substance Regulatory Authority in Jamaica, where he provides regulatory oversight on nuclear and radiation safety and security throughout Jamaica. He has served as a consultant to the International Trade Center, Geneva, a consultant to the Inter-American Cooperation in Agriculture, the general manager of Serendipity in Canada, executive director of the Scientific Research Council, Jamaica, an associate professor and associate dean of graduate studies and research in the College of Health Sciences at the University of Technology in Jamaica, an associate director in research and research and grants at our own Northern Caribbean University. He's a UWI graduate with a PhD in biochemistry, pharmaceutical, that was his emphasis, and a Master of Arts in teaching, and an undergraduate honors degree in chemistry and biology. He has served as the president of the Carrie Science, Chairman of the Board of Directors of the Jamaica National Agency for Certification, JANAC, Vice Chairman of the Climate Innovation Center, Trustee, Environmental Health Foundation, Board Member, the Diabetes Association of Jamaica, Commissioner, the National Commission on Science and Technology. He's currently the Director of the Carnegie Foundation for Cancer Research, which is responsible for today's lecture presentation. And the member of the Cannabis Licensing Authority Legal and Regulatory Committee, and member of the University Council of Jamaica of Science and Technology Advisory Council there. And he's undoubtedly well suited to present on today's topic, cancer and the environment. Is there a direct link? Welcome, sir. This one forwards it, this one don't do like me.
Thank you very much, Dr. Frankson. Good afternoon, everyone. Wonderful. I really want to express my gratitude to Bev, Carlene, and team from the Carnegie Foundation for Cancer Research. I saw Mr. Moore earlier. My very good friend, Prof. Giles, and also President Edwards. Thanks for having us, and thank you for hosting this event. Ladies and gentlemen, I think you may want to take your seats and listen a little bit more on how the environment impacts on the probability of cancer. It affects us all, whether directly or indirectly. A number of us are aware of persons who are suffering from cancer. We have been exposed to the psychological impacts of cancer, and there are so many different dynamics, and there are so many preventative strategies and approaches that we can employ in our own lives so as to ensure that if we do develop any form of cancer, there is early detection as well as different treatment options that are possible. So today I will explore the dynamics between cancer and the environment and whether or not there is a connection. How does the environment, how do our practices impact on the likelihood of developing cancerous cells and as such resulting in cancer? So I'll run through quickly, giving a quick idea of different types of cancers, the prevalence in the Caribbean as well as Jamaica, and also what environmental impacts are there, and give you some nice pictures of Jamaica in terms of some of the hazardous materials and how they may impact on you as an individual as well as your family. So it is quite known in terms of the main risk associated with cancer. What are these? First, genetics. There may be mutations in the DNA in particular cells. You have DNA alterations, you have hereditary related scenarios, and you also have ethnicity. There are some types of cancers you are more likely to have if you are of a black descendants as opposed to Caucasians and vice versa. Also, the next area you have to consider is age. What's the probability? If you are under 20 years old, the number of persons with cancers globally is like about 25 per 100,000. Within 40 to 50, 350 to 100,000. And if it's older, you're older than 60 years, you're looking at 1,000 in every 100,000 persons, or 1 in every 100. So age plays a major impact in terms of the prevalence of cancer. The next component is chronic inflammation. Do you have existing infections? Are you obese? And yes, a lot of scientific data is showing that obesity can have component effect in the likelihood of developing cancer, as well as looking at autoimmune diseases. The next component, and which I'm going to dive into a bit more, is substances in our environment. I don't know how many of you did titration while you were in high school. We did a lot of titrations with potassium dichromate. We used to throw it down the sink and all of that. By the time I left high school, I was told, oh, chromium-6 is one of the leading causes of cancers within the environment. So then you recognize more and more that as new knowledge comes to the fore, there are significant implications of the chemicals that we utilize on a day-to-day basis, whether in education or even for farming practices, like for glyphosate, as well as organochlorides and so forth that will impact on the likelihood of having cancer. And then other infectious agents, viruses, bacteria. We're all aware of HPV, Hep B, hepatitis C, H. pylori in their implication in terms of stomach-related cancers. But to give a little idea in terms of the numbers, because numbers are very important, and we have to understand where we are so as to ensure that we can respond in an effective manner. So when you look across the Caribbean, the second leading cause of death from non-communicable diseases in the Caribbean is cancer. Cardiovascular-related disease is number one. And then you look a bit deeper, you recognize that breast cancer is the leading cause of death among women in the Caribbean, followed by cervical cancer. But then you look on prostate cancer in men. Jamaica has a very high incidence of prostate cancer. Throughout the region, there's a high incidence of prostate cancers. 47% of cancers across CARICOM region are prostate-related, and another 24% related to lung. Colorectal cancer is emerging as well. That's number 3. So we have prostate, breast, colorectal cancer across Jamaica as well, which is another major factor. There's a very important part that Dr. Frankson touched on earlier, and that's looking on the mortality. And when you look at a global image in terms of cancer diagnosis and mortality, you recognize that globally, the survival rate among persons with lung cancer is relatively low. And there's a reason why I'm mentioning lung cancer, because we are very high risk for lung cancer within the environmental conditions. And I'll touch on that a little bit later on. But then you look on prostate cancer survival, breast cancer survival, colorectal cancer. Once detected early, then there are quite a number of treatment remedies in place. What are the environmental risks? And these are some of the things we need to discuss. You will see different information providing different guidances. But from the World Health Organization, it's believed that 20% of all cancers are due to environmental risk factors. And here we're talking about biological factors, viruses, bacteria, as well as toxins from fungi. We're talking about chemicals, such as chemical waste, your heavy metals, arsenic, cadmium, asbestos, and you're looking also on air pollutants, whether it be a radioactive gas or it may be the carbon monoxide and other air-related pollutants. Then you look on physical contamination. X-rays, UVs, other radionuclides, how do they impact on the incidence and prevalence of cancer? When you include nutrition and lifestyle-related practices, then the number shoots up a lot more to 99.
He suffers and dies. But why is this so? Now, understanding the complexity of disease is very important. Now, multiple myeloma, as we mentioned, is driven by a variety of genetic abnormalities, including changes in the chromosome number and structure and mutations in specific genes. Now, these alterations contribute to the diversity of the disease and can influence its aggressiveness and response to treatment. There's also immune dysfunction. Now, the immune system plays a crucial role in controlling cancer. Now, in multiple myeloma, the system is disrupted, leading to impaired immune surveillance and reduced ability to fight the cancer cells. That's how smart they are. This understanding is paving the way for immunotherapies that aim to restore the immune system function. What about the tumor microenvironment? The bone marrow environment where the myeloma develops plays a critical role in supporting survival and growth of the myeloma cells. Interaction between myeloma cells and other cells in the bone marrow can contribute to drug resistance. Now, we know that myeloma is a cancer of the plasma cells, but what exactly are plasma cells? So now let's quickly discuss B cells, which are our body's tiny defenders. So in our bone marrow, we make all the blood cells in our body. We have our red blood cells, our white blood cells that help to fight infection, and our platelets that help our blood to clot. Now our white blood cells, that's where our plasma cells come in. So imagine your body has a team of tiny defenders called B cells. Now these defenders are part of your immune system, and their job is to protect you from germs or cancer or any foreign agent that may harm you. Now, how do these B cells mature? So they are born in your bone marrow, which is like the training ground for your immune system. And as they grow up, the B cells learn to recognize specific enemies. Each B cell is trained to fight different enemies. Now, once they're fully trained, they travel throughout the body and go to your periphery, or what they call the secondary lymphoid organs, and they help to fight infection. Now, when a B cell finds its enemy, it activates and transforms into a plasma cell. And plasma cells are like factories that produce weapons called antibodies. Now, these antibodies stick to the enemy, marking them for destruction. So it's like it finds the enemy, tags them, and it says, here, body, come, destroy this enemy. So that is how it works. Now, when the B cells go wrong, we can have a condition called multiple myeloma. So sometimes the plasma cells become abnormal and starts to multiply out of control. Now, this leads to multiple myeloma. In myeloma, these abnormal plasma cells crowd out the healthy cells in the bone marrow and can cause problems in other parts of the body. Now that we understand the basics of development of B cell and the maturation, now let's dive more into multiple myeloma. In terms of the epidemiology, now it's an illness that affects blacks more than whites, and there's a slight male predominance. The median age of diagnosis is 65 years. Now this age is getting younger and younger. The youngest patient I've treated recently was a 29-year-old. So it's affecting our younger patients and it's affecting our workforce. Now, MGUS, which is monoclonal gammopathy of unknown significance, which is basically the plasma cell that is growing out of control, but it's not really causing any kind of effect, is a predisposing factor. So many of us may have this, but it may not cause any problems. So it's a predisposing factor. In terms of symptoms and clinical presentation, you can have bone pain, fractures. Now, pain in the back, ribs, or other bones often worsen with movement. You can have fatigue, weakness, anemia, which is low red blood cell count, causing pale skin, shortness of breath, and fatigue. You're at higher risk of infection because your immune system isn't working properly. And there's hypercalcemia, which is high calcium levels in the blood, and you can have renal impairment. Now, here's a picture just highlighting a patient with multiple myeloma that have bone lesions. So you can see here, this is an X-ray of the skull, and there are little tiny holes or lytic lesions on the patient's bone. And this can happen throughout the body to all the bones and can cause significant pain and morbidity. Now, how do we investigate? Now, diagnostic investigations include blood tests like your complete blood count, your chemistry panel. We look at your serum protein electrophoresis, and I will explain all of this. We can look at another test called immunofixation electrophoresis. We also look at your bone marrow. Now, I told you that your bone marrow makes all the blood cells in your body. So we would want to look at the bone marrow, examine it, and confirm the diagnosis by looking at the number of plasma cells that is in the bone marrow. We also do imaging studies like your X-rays, CT scans, MRI. And as you can imagine, your CT scans and MRIs are more sensitive in picking up these lytic bone lesions than X-rays. Now, what are antibodies? So I said to you that plasma cells produce antibodies. And I also use a term called monoclonal. What is all of this? What am I talking about? Okay. So here we have our healthy bone marrow, and we have plasma cells, normal plasma cells, and normal antibodies being made. And here beside it on the right side, you have multiple myeloma. And you can see here there are numerous amounts of plasma cells just crowding out the good cells in the bone marrow, and one type of antibody being made, right? Or antibodies are produced to help to fight infections. And usually there's a wide range of antibodies that are produced. So just like I told you about the different variety of flowers, you have different kinds of antibodies that help to fight infection, survey your body, and do what it needs to do. In multiple myeloma, we don't have that variability in the antibody. We just have one type being made. So when something goes wrong, that's how we get multiple myeloma. So remember, these plasma cells are like factories. So these factories produce the antibodies. And as I told you, something goes wrong, so it's just producing one type of antibody. So picture you have a factory that's supposed to be producing a variety of garden tools. And then all of a sudden it's just producing one tool. Or you have a factory that's producing any kind of tool. For example, it's just overproducing hammers, and you just have a significant amount of hammers just crowding out the place. It's going to cause problems. This is what I'm talking about when I say monoclonal. It's just one type of antibody that's being produced and causing problems. So here I just have another picture showing normal plasma cells and multiple myeloma cells here at the bottom. And this picture here towards the right side is what our antibody looks like. So we have our two light chains here at the top, and we have our heavy chain at the bottom. Now, I told you about these abnormal proteins or monoclonal proteins that are being produced. Now, it can be tested as part of our investigation for multiple myeloma. So we have a test called the serum protein in electrophoresis. Now, this test looks at our monoclonal protein or otherwise called our M protein in the blood. And it will find it about 82% of the time. So yes, there's a high sensitivity, but other tests actually have a higher sensitivity. So we have our serum immunofixation electrophoresis, which is another test that's a bit more specific in identifying this M protein, and it detects it 93% of the time. You have another test called the free light chain assay, and this also looks to see the M proteins that are freely floating around in the blood. And you have other tests that can look at the M proteins in the urine. Now, the combination of these tests detects the M protein in 97 to 98% of patients who would have multiple myeloma. So you can imagine if we only stopped at the serum protein electrophoresis and it came back negative and the patient actually had multiple myeloma, we would have missed it. So the combination increases the sensitivity and the likelihood of picking up the test. But here's the issue. These tests are very expensive. And as you get higher in its sensitivity and specificity, the test is more expensive. And this is one of the barriers that we have in our healthcare system. So what are the treatment strategies? So we have induction therapy, right, which is the initial treatment. And this initial treatment is used to reduce the tumor burden, so the amount of myeloma cells that we have. And it often includes a combination of chemotherapy or other targeted novel therapies. We have our consolidation. So this is high-dose therapy with stem cell transplantation, which aims to deepen response and prolong remission. So you see, multiple myeloma is incurable, but the goal is to try and put you in such a deep remission that the likelihood that we decrease the likelihood of the disease coming back and you being symptomatic of the disease. Now there's maintenance therapy, which is a long-term therapy. Now this therapy is used to sustain the remission, and it may include different variation of drugs. So basically combining all of these therapies, targeting the myeloma at different angles will help to offer significant improvement in overall survival. So here is just a table showing the treatment arsenal available. So we have our chemotherapies like our alkylating agents or cyclophosphamide and melphalan, which causes DNA damage, interfere with cell division. And as I mentioned, the other classes earlier. Now, there's another class called nuclear export inhibitors, or selinexor, which is relatively new as well, and it blocks the transport of essential molecules from the nucleus, disrupting cell function and leading to cell death. BCL2 inhibitors like our venetoclax blocks protein that helps cancer cells survive, making them very effective and susceptible to death. Now, CAR-T cell therapy, now, we have our ide-cel, which is basically genetically modified your T cell, which is part of your white blood cells in your body, you have your B cells and your T cells, and it's genetically modified to recognize and kill the myeloma cells. And it's also used in a different variety of cancer cells, of other cancer as a part of the treatment, sorry. So the myeloma treatment arsenal, this is what it is. And there are even more. This is what we have available. So this is the individual benefits that the National Health Fund offers: dexamethasone, melphalan, which is a chemotherapy, and we have an antiemetic, and we have filgrastim, which helps to stimulate the bone marrow to produce white blood cells. So in cases where sometimes the chemotherapy would affect the bone marrow too much and the patient needs help in recovering the bone marrow, the white blood cells of the bone marrow, we give them filgrastim. So it's mainly supportive care that we have on this. We don't have any of the novel agents available, and we do have chemotherapy available, but as we already know, the chemotherapy is not as effective as these novel agents. Now, just quickly, I just wanted to mention something about minimal residual disease again. Here is just an iceberg showing tumor burden at baseline and our complete response. So when we look at our labs, the regular baseline labs that we do, we can see, okay, the patient has, resolution of symptoms, the labs are okay, the blood counts are fine, but look at the significant amount of disease that's still there in the deep blue. What we try to do is get it undetectable. So we want to decrease the tumor burden so low that we have undetectable minimal residual disease. So I just wanted to wrap up quickly here just to show that, so for example, if we had a patient here, Mr. J, who is 60 years old, diagnosed with multiple myeloma, we choose a regimen. Now the patient presented with fatigue, back pain, weight loss, investigations confirm multiple myeloma. Here, the patient had ISS stage 2. We were able to get the cytogenetics done, and it showed that he has high-risk cytogenetics. So the patient was placed on induction therapy with a 4-drug regimen, and then went on to receive autologous stem cell transplantation. As you can see here, there was significant reduction in tumor burden after the first cycle. Cycle 2 to 4, continued tumor reduction with near complete response by the end of induction therapy. And post-induction, he successfully underwent stem cell transplantation, leading to long-term remission. And he is currently doing well and is being monitored for minimal residual disease. This is what we're talking about when we talk about personalization of treatment for multiple myeloma. But overcoming the barriers we have, cost consideration, time delays. So even though the testing and the treatments are available, because they're not directly offered here in Jamaica, there are time delays for these tests. So we have to send it overseas, and it can take 2 to 3 weeks, sometimes a month, to regain and to get back the test results. Regulatory challenges, getting approval for these genomic-based therapies, and privacy concern for the patients. So education is key to both patients and healthcare providers. So future directions, the field of myeloma treatment is continuously evolving with new therapies and innovative approaches, and a deeper understanding of the disease are promising for the future. So key takeaways from this presentation: genomics provide unprecedented insights into the biology of cancer, enabling development of personalized treatment strategies. Multiple myeloma is a prime example of how genomic information can guide treatment decisions and improve patient outcomes. And addressing disparities in access to genomic testing and personalized medicine is essential to ensure equitable cancer care for all. So these are my references. Thank you very much.
Okay, I just want to say to everybody how much I appreciate your cooperation. What you did, whatever it was, it made a world of a difference. We were able to enjoy what you have with your individual approach and also to enjoy our presentations. And we really had a great presentation there a while ago. You have to pay for this stuff. It's so valuable, but you're getting it gratis. Care of NCU. Thank you so much for coming in the first place. I'd like to introduce you to now Dr. Darion Walker. He's the head of the undergraduate radiological sciences program within the Faculty of Medical Sciences at the University of the West Indies, and a medical physicist. I always wanted to be a physicist. University of the West Indies, and he was the founder and the CEO of Radiation Physics Limited, and has been an educator at the tertiary level for over a decade. Dr. Walker also lectures in the MSc Medical Physics program within the Department of Physics, as well as in the Doctor of Medicine program in the Faculty of Medical Sciences at UWI, where he teaches the physics of radiology. A trained radiographer and medical physicist, Dr. Walker's record for excellence in the field of radiation science is bolstered by his honors degree in diagnostic imaging radiography, medical physics, and a PhD in applied physics. He is board member of the Council of Professional Supplemental to Medicine, Ministry of Health and Wellness, as well as a board member of the Jamaica Association of Physicists in Medicine. Listen now as he expounds on Theranostics, a new paradigm for cancer treatment in Jamaica. Dr. Walker, come right ahead, please.
All right, thank you. All right, good afternoon, everyone. Thank you all for being here. So I'll be presenting on Theranostics, a new paradigm in terms of cancer treatment in Jamaica. So some of you may be asking, what is Theranostics? What really is that? When you think of cancer therapy, the first thing you think of is chemotherapy, where we use drugs and chemicals to treat the cancer. Theranostics is where we use radiation in combination with pharmaceutical drugs to treat that cancer. What you will find happen with Theranostics is that we are going to combine just waiting for the PowerPoint to be up. All right, working on it. I need the images. Yeah. All right, so while we get the PowerPoint up. So what Theranostics is that we're going to combine the therapeutic effect of radiation with the diagnostic effect that we use it for. So that is where we get the word Theranostics from, therapeutic and diagnostic. So we put them together, we get Theranostics. But you find that cancer cells in your body, they have different receptor binding ends. So when you're diagnosed with cancer, one of the first things that they look for is to identify what type of cancer it is and the respective proteins that that cancer comes with. Based on that protein, they can now determine that targeted therapy. Can we treat this cancer based on the respective proteins that it presents with? Especially in breast cancer, you find that we have three specific ends that we look for. If you're triple negative, then it means that it is very difficult for us to treat it because it's almost as if we can't identify it separate from the rest of the body cells. if you think about, for example, pancreatic cancer. Now, pancreatic cancer is not a popular cancer, but it is very deadly. And one of the reasons it is very deadly is because they look like normal pancreatic cells. So the body doesn't look at a pancreatic cancer and say, you don't belong here. It looks at the cancer thinking it is a normal pancreatic cell, and thereby it ignores it. One of the things that we do to help treat pancreatic cancer is that we use what we call cytokine suppressors, and we use immunotherapy. So we try to train the body to identify that there's a cancer here. Now, what you find, however, with Theranostics is that once there is a protein-binding end that we can identify, then we now can use pharmaceutical products to attach to those cancer cells. So let's say, for example, you have prostate cancer. If you have prostate cancer and that cancer is contained within the prostate, then you find that we can use external radiation beam and we can treat that cancer. That is what we call radiation therapy. But let's say that cancer is spread throughout the body. Then it's not in one location anymore. We can't just shoot the radiation in one location. It's in so much areas in the body. So we now need to inject within your body a pharmaceutical product that can identify the cancer cells wherever they are. Now with Theranostics, what we do is that we combine that pharmaceutical with a radiation or radioactive isotope. So when that pharmaceutical attaches to the cancers in your body, then the radioactive isotope will give off radiation in those locations, and through imaging, we can now map throughout your body where the cancer cells are. After mapping throughout your body where the cancer cells are, we now can determine, based on the response to the diagnostic procedure, we now can determine the effectiveness of therapy using radioactive isotopes similar to the one that we used for diagnosis. I see I have the PowerPoint on this screen. Can I have it on the large one? So if you see on the side screens here, we have performed our initial scan. And what we're doing is that we're identifying how many of the cancer cells presents with the targeted end that we're looking for. If the cancer cell that we have, if the cancer we have identified does not present with any of the binding ends that we need, then we can't use Theranostics to treat you because the pharmaceutical simply can't find the cancer. However, when it can find the cancer, those are the ones that are in red, then you find that we can now say we can target this amount of the cancers in your body using Theranostics. Now, when we treat using Theranostics, what we're really doing is that we inject that pharmaceutical product, and but we first combined it with a radioactive isotope. So when we combine it with the radioactive isotope, you find that that radioactive isotope now serves as the killing effect. So we all understand that radiation in general terms is not good for your body. If you get too much, it can induce cancer, but thankfully as well, you can use it to kill cancer. So what we do is that we bind that pharmaceutical product with the radioactive isotope, and we inject it in your body. It will circulate through your blood system, and it will find wherever the cancer cells are, and the pharmaceutical component will latch on to the cancer cells. The radioactive isotopes, however, will now be emitting radiation and begin to kill that cancer cell. Now, it can emit that radiation using one of two main forms that we use for treating cancer, using what we call alpha radiation or beta emission. And I'll get into that a little bit further. So after we perform the course of treatment, we then do another diagnostic scan, and we look to see how effective the treatment was. If we realize that it has shrunk the cancer or the number of cancers in your body, then we can determine based on blood toxicity whether or not we can give you another course of treatment. And if we realize that it has eradicated the cancer, then there's no need for a second course of treatment. So all of these are done through assessment after you have been treated. You can see here on your screen that we use radioactive isotopes to locate the cancers in your body. So the skeletal scintigraphy that we have done that is for bone metastasis, oftentimes from prostate cancer. And you'll find as well that we look at neuroendocrine tumors, thyroid cancer. All of these respective cancers can be identified using diagnostic imaging through nuclear medicine. I want to show you some results, if I can get it moving. All right, so before I show the result, let me show you the difference between beta and alpha. So alpha particles, they don't penetrate deep in your body. So when we allow that radiation or that radioactive isotope to be near the cancer, it is really focused on killing the cancer, not so much the healthy tissues around that cancer. Beta is a little bit more penetrative. So you find that beta particles will now penetrate the cancer as well as will interact with some normal tissue. So when the physician is determining what treatment to give you, they look at the type of cancer you have, and then they determine which one will be most effective. I want to show you some results as well that we have used for treating cancer. I want to show you the first image is from thyroid cancer treatment. So the image on your left would be the cancer cells that were visibly demonstratable under the microscope. But after using radioactive sodium iodide therapy, you find that it eradicated the cancer cells that were related to thyroid cancer. What this does really is that the thyroid is really avid to iodine. So we oftentimes use iodine starvation like 2 weeks before, so that when we do give it that iodine, that radioactive iodine, your thyroid cells will now suck it up avidly, and then you find that it now concentrates that radioactive isotope in the thyroid cells, killing the cancer that is still left behind. Oftentimes we do surgery before, and we would take out the thyroid, but when you do the surgery, the cancer cells have already spread, oftentimes. And we just want to make sure that anywhere that it is that they have gone, we can track them down and we can treat them. And the way we do this is by administering that radioactive sodium iodide. Because even if it is that we can't see a mass, the beautiful thing about Theranostics is even in the absence of the mass, the cancer cells can be identified. And when the pharmaceutical bind with these cancer cells, then the radioactive isotope now emits the radiation, killing these cancer cells. So you might do a CT scan post-ablation in taking out the thyroid. And the CT scan may not show any cancer cells because they are not visible in terms of any anatomic change. However, cellular base, they are there. And by using nuclear medicine, we can identify them. And after identifying them, we then can treat them. One of the best treatments that we have is for bone metastasis. So we have palliative treatment for bone metastasis, oftentimes from either prostate cancer or breast cancer. So when you take out the prostate, you may have taken off the breast, but the cancer have already spread and it has now been impacting the bone. It hurts a lot, and what we try to do is reduce the number of cancer cells within the bone. And how we do this is by first we use chemotherapy, but then we use radium-223 or we use actinium-225. And these are alpha emitters that the bone will now absorb, because the bone cannot differentiate, or the body cannot differentiate between radium and calcium, because they both have what we call a +2 cation charge. So it will suck up the radium thinking it is calcium to make bone. And then when it sucks up the radium, it is actually sucking up the radioactive isotope, and then it kills the cancer cells, because the cancer cells, they will be replicating faster than the normal bone cells. So they would have sucked up, or they would have absorbed most of the radium-223, and thereby killing themselves because they would have been absorbing a lot of radioactive isotope. You can see on the image there what the cancer looked like. So the dark areas on your image on the left indicate the spread of the cancer before theranostic treatment. And after Theranostics treatment on the right, you'll see that the body, not 100% clear of the cancer, but it has significantly reduced the cancer within the patient's bone, as well as in the body. Now, this is not a cure. We call it palliative treatment because it's really for pain management. It may add to your life an additional 8 months to an additional 1.5 years or 2, but what it does is that it improves the quality of life or end of stage that you will have. A lot of time, cancer patients, they suffer. They suffer a lot of pain in the latter end of the cancer. What palliative treatment through Theranostics can do is reduce that suffering. I'd like to also show you another result. And this time was a combination again of chemo and theranostic, but this time we use what we call lutetium-177. And this time you find that the treatment was even more effective. So what we realized is that by combining chemotherapy, conventional chemotherapy, with Theranostics, it improves the patient output and prolongs that patient life and quality of life a lot longer. Additionally, we use Theranostics for metastasis to the liver, in terms of you may have had non-primary liver cancer, but it spread to the liver. And we use yttrium-90, and we treat this liver metastasis, thereby, again, extending the quality of life that the patient has. Theranostics can cure in some instances, but in some instances, it's not so much to cure the patient, but to improve the quality of life that the patient has. It can extend your life for 5 years, 15 years, 20 years. If you have non-castrate-resistant prostate cancer, then you find that you can live another 20, 30 years post-treatment. But when you have castrate-resistant cancer, you find that it's a lot more difficult, but Theranostics can improve your lifespan by additional 5 years. Now, the biggest challenge we have with Theranostics, of course, is the cost. And oftentimes patients may ask, why should I spend so much money on something that I might only get 5 years, 2 years, 8 months? And that's a good question, but sometimes you realize that you're improving the quality of end-of-stage life. And importantly, it gives you another holiday with your loved ones. It allows you to see another graduation. It allows you to walk your daughter, your son down the aisle. It allows you to be in your family's life a little bit longer. And therefore, you realize that it is not so much the healthcare that you're paying for, but it is the additional time that you're paying for. As we progress with innovation and research, then we will reduce the cost of these treatments. We have some of these treatments currently on offer at the UHWI, but we need to increase the access of this treatment throughout Jamaica. In conclusion, you find that it is one of the leading fields in terms of cancer therapy today. It is where the world is moving to, especially for patients that are in a no-win situation. In other words, they are terminal, but this can extend your life by an additional 8 months to 5 years, depending on what the illness is. As we tackle the cost of these treatments, as more and more investment comes into this field, you find that with everything else, the prices will come down as well. These are my references, and I thank you for listening.
Well, we have spent a really valuable time here today. I'm sure you are getting a lot of interactions with the various displays that are around, but our presentations have been really on target. Thank you so much to everyone. My last presentation for today, we're going to have to skip another presentation that was scheduled to follow that, but we're going to, just in the interest of time and for what else is booked for the day, our last presentation will be by Dr. Casey Reed, Director of the Cancer Research Institute at Northern Caribbean University here in Mandeville, Jamaica. And he's Assistant Professor, Director of the Cancer Institute, and Supervisor of the Agri-Research Laboratories. Dr. Reed is a molecular biologist and a medical technologist certified by the American Society of Clinical Pathologists. He holds a PhD in biology and an MSc degree in molecular biology, which is a project at Loma Linda University on the characterization of the MUT-Y gene in Porphyromonas gingivalis, as well as a Bachelor's of Science degree in medical technology from the Northern Caribbean University. His primary research interests include the study and development of the anti-cancer and other bioactive properties of Jamaican indigenous plants, with the aim of creating novel evidence-based therapeutic nutraceuticals. He has already contributed to the development of plant-based formulations with health-enhancing benefits, which are currently being studied for optimization. I welcome Dr. Reed at this time. Dr. Reed is also presently serving as the Assistant Professor in the Department of Medical Technology, while he lectures in the course of Clinical Chemistry, clinical biochemistry and molecular diagnostics. He's going to talk to us today about the case of a regional cell and tissue bank. Welcome, Dr. Reed. You've been doing so well with the applauses, even though I've never asked for them. Let's continue.
Thank you, Dr. Frankson, and good afternoon, everyone. I'd like to thank you for your patience. I'd like to thank you for your presence here, and for those who are still here, I'd like to engage your attention for a few minutes. Given the time limitations, I will truncate my presentation to hit a couple of points that I think are extremely important. I'm very pleased to have this opportunity to discuss a topic which, in my view, is of immense significance. For the past hour and a half, you've been given a wealth of information. And I'd like to commend the previous speakers for the value of the information. And if I could summarize what has been said so far, I'd say that we have made some very interesting strides in our ability to manage cancer. No doubt you are given the frightening statistics of cancer, and you've heard how cancer continues to plague our society and to threaten our peace of mind. I don't think there is any disease like cancer in regard to the fear it causes in people. Think about any other disease. When you hear that someone has cancer, it's a hard thing. It seems, it feels like a death sentence. And in many cases, it still is. But the improvements that we have made in our ability to manage cancer is primarily due to advances in technology, and particularly the evolution of a concept called biobanking. All of the technologies, the innovations, the treatments you heard about are due in part to the activities of cell biobanks, which in turn spawn what we now consider precision oncology or personalized cancer treatment. This is where cancer management is and is going. Here's a very short summary of how precision cancer treatment works. You see, we have these cell biobanks, which are repositories or institutions that collect samples from patients. And these samples could be blood, DNA, cells, biopsies of cancers. And these samples are collected from patients who have specific cancers. The personnel in these biobanks then use the samples in research studies to get specific information about these samples. The information derived from these samples and these studies are then used to formulate specific treatments and incorporate them into specific strategies that are most effective against these types of cancers. Once you have a formulation prepared using the information derived from the research studies, these drugs or treatment strategies are then incorporated into clinical trials in which they're tested in the human population to determine efficacy and safety. So you could say that cell biobanking or biobanking in general has given rise to precision oncology or personalized cancer treatments. You could also say that clinical trials most directly impact the production of cancer drugs and cancer treatment strategies. Understand, therefore, that the nature of the clinical trials and the inclusion in clinical trials is paramount in producing drugs that are effective for a wide cross-section of people. And this brings me to my main concern. The participation in clinical trials have been unacceptably lopsided in favor of a few ethnic groups. Minorities have traditionally and historically been underrepresented in clinical trials. And as I mentioned, the information from clinical trials has perhaps the most direct impact on the type of cancer drugs and treatment strategies produced. I'm going to spend 1 minute to summarize the history of cell biobanking to give you a better idea of its value. Cell banking could be thought or can be thought to originate in 1951 when at Johns Hopkins University Hospital, an African-American woman underwent a surgery. Her name is Henrietta Lacks. And after the surgery, they collected cells from her body without her consent, I should add, and used those cells to create what are called immortal cells. Those cells, which are now called HeLa cells, was the first inclusion in a biobank. Since that time, the proliferation and the establishment of cell lines from different tissues has proliferated over the years. It got to a peak in the 70s and the 80s. And the proliferation of cell lines for medical research was of such that it necessitated formal, organized bodies to regulate and validate the quality of these cells, because obviously these cells are being used to produce treatments and drugs for different conditions. From that time, I think it was in 1965, where the first regulatory organization for cell lines was established. That was the American Type Culture Collection, commonly called ATCC, where we buy cells from. As I mentioned, cells like these are used in scientific research to figure out and formulate specific treatment strategies for various cancers. As I mentioned, the biggest problem that we have as a people is that there is unacceptably low representation of black individuals in clinical studies. All right. I had a graph here that I wanted you to look at. If the person upstairs could assist me with this. Okay. Oh, I got you. Could you go forward, please? To the graphs, to the graphs. Yeah, that's it. Okay, so the first major issue, as I mentioned, is the fact that black individuals are woefully underrepresented in clinical trials. Between June 2008 and July 2018, there were 230 clinical trials, 230 cancer clinical trials that led to the development of FDA-approved drugs which are now being used. I repeat, there are 230 cancer clinical trials that led to FDA-approved drugs for cancer. In these studies, the average participation of black individuals was 3%. The left graph you're looking at highlights this fact. There were 4 major ethnic groups that were included in these studies: Caucasians, Hispanics, blacks, and other. Asians. Now, bear in mind that black individuals make up the second highest ethnic group in the United States. Yet, our participation in these clinical trials was 3%. Now, can you understand the implications for our community? I'd also like you to bear in mind the fact that cancer disproportionately affects black individuals. A black male is twice more likely to die from prostate cancer than a female. And the same is true for our black females. I mentioned earlier that the most important information from clinical trials are used for drug approvals. Now, if we are underrepresented in clinical trials, you can understand the implications. The other point I'd like to make is the fact that the black population is a genetically very diverse population, to the extent that the average African American has a genome consisting of 71% African ancestry, 13% European ancestry, and 8% from other groups. Afro-Caribbeans have a similar breakdown, with also the inclusion of contributions from native Caribbean islanders. The implication of this in clinical trials is the fact that most clinical trials do not account for the gene differences in our black population. A study was done by Paulo Panera and his colleagues, and he found that the disease susceptibility or the cancer susceptibility differs among black subgroups. Now, what is the implication here? If black individuals are aggregated as one group, drugs and treatments produced from these clinical trials do not account for the nuances that exist in our genome as a population. And here is my thesis. even though the FDA and other regulatory bodies, they draft policies and they draft standardized recommendations to improve the inclusion of minorities in clinical trials, the problem remains. It has remained. Okay? I would like to use this opportunity to begin a conversation in which I make the case for the establishment of a regional cell and tissue biobank that overrepresents our ethnic group. This may sound like a very ambitious goal, and it really is. However, I'd like to point out that the history of cell biobanking began as a very diffused project. As a matter of fact, the first biobanks began as little pockets of repositories in universities where researchers simply collected leftover aliquots of samples from their colleagues in the hospital and began to research on these samples. They pretty much stored samples in freezers and deep freezes, and they collected and stored data in laboratory notebooks and computers. We here at Northern Caribbean University are determined to contribute to the fight against the disproportionate effect of cancer on our population. We want to begin as was done, where we start with our small repositories of cells, of tissues, and begin to study our own people. Begin to understand the nuances that affect our population. We want to understand how cancer affects different subgroups within our population. And this is the reason I'm happy that we have an audience that consists of academics, clinicians, business people, and alumni that love our school and love our country. Because we want to partner and begin this collaboration to establish the makings of this cell bank, which I believe will quickly evolve into a regional cell and tissue bank where we can study our own people, we can overrepresent our individuals in clinical trials and produce drugs, and cancer treatment strategies that reduce and minimize the scourge on our people. Thank you very much.
Thank you very much, Dr. Reed, and to all the participants and presenters for the Carnegie Foundation lecture series. We appreciate your having come, and we appreciate the audiences that have been with us, and thank you for continuing to direct today. I'm inviting Ms. Carnegie to bring, Ms. Carleen Carnegie, could you kindly come with the presentations that we have of wheelchairs, nothing else, just the wheelchairs, and I'm inviting from Dr. Frankson and Mr. Seavright, because we do have this presentation to make. And if they are not here, then we will just have someone take a picture of the wheelchairs as we get them here. Can we come quickly, please? Because there's another program that is scheduled, and we are past due, and they are changing the information online because persons are watching and needing to know what's happening. Please come. And ladies and gentlemen, we really appreciate all that has been done Okay, we're going to ask the president if he would just come. Lots of presentations today, Mr. President. And right after, we're going to take pictures with the presenters and Mr. Johnson, Mr. Leonard will tell us. Thank you very much. Could we just line up for a photo here? Dr. Frankson, we know that the ambulance always needs stuff, and we are, in addition to the one for the health services, so one for the health services and one for the ambulance. Now we have, while they're figuring out how to position for the taking of the photos, we continue to assist not only the hospitals and the nursing homes and individuals, but we also have been assisting the university for the past 12 years in getting equipment and materials for the schools, the various schools within the university. Thank you very much, ladies and gentlemen. And thanks for the photos. And Mr. Danita Murray, I know, is anxious for the next program to begin. So thank you, ladies and gentlemen, as you folks are gathering for the next program, which is a raise of distinction. I almost said raise of hope, but it's a raise of distinction that is coming up next. But thank you. And remember, there are lots of other things that are happening with the alumni, and the 100th anniversary of the formation of the Alumni Association at Northern Caribbean University. Thank you very much, ladies and gentlemen. Oh, and I should have mentioned that one of the challenges we had is that the internet went down, so it pushed our systems back. Thank you.